Orbital cavity is one of the major cavities when we are discussing the facial features. So there are a lot of diseases, and among the range of diseases, we know that there are multiple infections that can occur in this orbital cavity, as well as there can be a lot of tumorous conditions, thrombotic conditions that can arise in this orbital cavity. The contents of the orbital cavity can get infected, they can be subjected to trauma, they can be subjected to multiple infectious states, and that would result in the differentiation of the anatomical features of a normal orbital cavity. So to get to know the diseases that are involving the orbital cavity, one should know the anatomical features, and predominantly, obviously, when we discuss the orbital cavity, we discuss it by the different walls that it contains, because that would further classify the orbital cavity into the bones that are the main constituents of this cavity. We'd be discussing the medial wall, which is one of the major walls of the orbital cavity. And then obviously there is a roof, there is a base, and then there is a lateral wall to this orbital cavity. Just when you want to imagine this orbital cavity, you should know that it's basically a pyramidal shaped cavity having its base anteriorly and its apex is basically located posteriorly. At its apex, it has very important fissuring structures. That is basically the superior orbital fissure, and we have an inferior orbital fissure lying over here. Some very important structures involving the ophthalmic veins, the superior and inferior ophthalmic veins, ophthalmic arteries and nerves, they basically pass on to the cranial fossa. So infections can basically travel from this orbital cavity to the cranial fossa, either it's the anterior cranial fossa or the middle, or eventually it can reach up to the posterior cranial fossa. So this is basically a very important communication that we have to consider. On the other hand, we have communications with the nasal cavity through the nasolacrimal duct. So infections can basically travel vice versa, either from the orbital cavity to the nasal cavity or from the nasal cavity to the orbital cavity quite easily. As well as you have to keep in mind that the paranasal sinuses are also communicated with the orbital cavity. So we have to keep that even in mind when we are discussing the different sorts of orbital diseases over here. Mainly today we'll be just summarizing, or we'll be just focusing our discussion on the congenital anomalies that can occur in the orbital cavity. Now, orbital cavity in itself is not basically having congenital anomalies. It's basically the whole skull, or usually it's the syndromic conditions that arise in the children. And due to the fact that you have to consider at the back of your mind that basically we have the different sutures lying in our facial features as well as in the whole skull. We'll be discussing the different sutures over here. Predominantly, we have the coronal suture and we have the sagittal suture over here. It's basically, I'm talking about the vault of the skull. So when you look at the skull from a superior view, you just have a look at the vault of the skull, which has a coronal suture and it has a sagittal suture. So if there is a premature closure of these sutures, that will basically result in an abnormal shape of the skull, which is basically known as craniosynostosis. So that is the basic concept that you have to keep in your mind when we are discussing this condition, which is known as craniosynostosis. Cranio is a word that is basically indicating that this is a condition of the skull. The anatomy of the skull is distorted. It's a congenital condition. Usually these conditions are autosomal dominant in their nature. So you have to keep this, all of these facts in your mind when you have an infant and you're examining that infant. You observe that there is some sort of an abnormality with the shape of the skull, with the size of the skull. Then you can consider that this particular infant can be suffering from one of these sorts of craniosynostosis. Obviously, we divide these premature closures of the sutures into different categories over here. Even it can be of different intensities in these infants. It can be a mild, a moderate, or of a severe intensity. Then there are multiple shapes of the skulls that are given due to this premature closure of the sutures. Then the different bones that are involved in the face of an individual, that is basically the zygomatic bone, we have the maxilla, we have the mandible. There can be a hypoplasia of these bones, and that will also distort the facial features of that individual. And obviously, even that is going to affect the capacity of the orbital cavity over here. So usually these infants have these typical features. That is basically one of the very important feature over here is the telecanthus. Telecanthus is when the medial canthi are basically quite obviously they have an enlarged distance, an abnormal distance in between the medial canthi. We call this condition as telecanthus. They have usually these skulls that are quite elongated, these babies, and usually they are termed as a tower-shaped skulls, boat-shaped skulls, depending upon the particular condition, depending upon the particular individual whom we are dealing with. So there is a range of anomalies when we are discussing this craniosynostosis. Either it can be due to the premature closure of the sutures in the infant, or there can be the premature closure of the fontanelles in the infant, or either there is the hypoplasias of the different facial bones. May it be the frontal bone, or either it is the zygomatic, the maxillary, or the mandibular bone that we're talking about, and it would be different in different cases. So it's not just a particular typical feature that we usually see in these infants. These children can suffer from Brachycephaly, or either it can be the Oxycephaly that they are suffering from. Usually this kind of the abnormality is known as the clover-shaped skull is observed in these individuals. The coronal sutures are basically involved. There is a premature closure of the coronal sutures in these individuals. Then there can be the Scaphocephaly, or on the other hand, we have the Acrocephaly, and usually these children are suffering from the boat-shaped skulls. So it's a slightly enlarged skull, and it's basically giving the appearance of a boat shape, and that's why it's known as a boat-shaped skull in these individuals. The sagittal sutures are mostly involved, and the multiple other cranial sutures can be involved respectively in the acrocephaly. So when we talk about the scaphocephaly, it's basically the sagittal suture, and in acrocephaly, we have the other sutures also involved. On the other hand, we have the Trigonocephaly, and in this condition, we usually call the skull an egg-shaped skull. So this is the different shapes that we usually see, and even in this picture, you can guess that it's basically a Trigonocephaly, giving it an egg-shaped skull. Usually the frontal sutures are involved in this kind of an abnormality in the shape of the skull when it is observed in the children. So it's just not the shape of the skull that is affected in these children. Usually there is a mental retardation that is observed in these individuals, and they have a low IQ that is also kept along. The orbital cavity, the structures of the orbital cavity are quite compressed in these individuals due to the fact that the contents of the orbital cavity are quite squeezed down, as well as there can be an optic nerve compression that is noted down in these individuals due to the fact that the orbital fissures are also closed down. So there would be the compression effects that is noted down just by the change in the shape of the skull in these infants. So we have another condition that the infants can suffer from, and again it's due to the premature closure of the sutures. It's known as the Craniofacial dysostosis. Another name which is also given to this kind of a condition is known as the Cavernous syndrome. Now this condition arises due to the fact that there is a premature closure of the sutures, and along with this premature closure, there is the hypoplasia of the maxilla that is also noted down in these infants. So this is again one of the congenital anomalies. It's again an autosomal dominant condition that can arise in these children. Again, there would be these particular features that these infants are suffering from. There would be the features of telecanthus, that is an increased distance between the medial canthi that is noted down, and along with that they have a high arched palate. Then addition is going to be affected in these individuals, as well as there are going to be slight nasal deformities also observed in these children. Obviously, they would be suffering from a mild condition of a mental retardation as well. So usually this mutation is at a genetic level. When we're discussing this condition, you should know that it's almost a 25% mutation noted down at the genetic level whenever we have these babies with craniofacial dysostosis. The ocular features for the craniofacial dysostosis are the proptosis due to the shallow orbits. Again, there would be a difference in the shape of the skull that is noted down in these individuals. So obviously the orbital cavity is going to be affected, and that would make the orbital cavity much more shallower in these individuals. And that would obviously result in the proptosis. The V pattern of the exotropia is noted down, and obviously there would be a hypertropic condition also examined in these individuals. These infants would be suffering from optic atrophy due to consistent compression of the optic nerve, and as well as hypertelorism. Telorism or hypertelorism is basically another term that is related to the condition which was already called as telecanthus, increased distance between the medial canthi, but the interpupillary distance would remain the same. So that is the slight difference between the two terminologies of hypertelorism and telecanthus in these infants. The other ocular associations would be a blue sclera, which is also the megalocornea noted down. This would be due to the ripping at the histological features of the scleral wall. And iridia or glaucomatous conditions, it would be a condition which is quite resembling a closed angle glaucoma due to the fact that there would be the closure of the angle, there would be this increase in the intraocular pressure that is noted down in these infants. The infants may also suffer from a congenital cataract along with this condition, ectopia lentis, and as well as the optic nerve hypoplasia is noted down. For this observation, you have to carry out the radiological examination of the skull, that is through the CT scans or the magnetic resonance imaging that is done for these patients. The systemic features for the craniofacial dysostosis would include the mental retardation that is noted down. If you perform the IQ test on these children, you would note down that they suffer from a lower IQ level. A high arched palate is noted down. A hooked nose is a very important phenomenon over here, and irregular dentition due to the abnormalities of the palate. Obviously, if there is going to be a high arched palate, that is going to affect the dentition of the individual as well. Another condition which can arise due to the premature closure of the sutures as well as hyperplasia of the mandibular bone is known as the mandibulofacial dysostosis. So it's basically depending upon which bone is affected in the patient. If it's the mandible, it's going to be a separate condition. If it's the maxilla that is involved, it's going to be an entirely separate condition, an entirely separate syndrome. So sometimes we usually come across these patients where there's the distortion of the facial features along with this premature closure of the cranial sutures, as well as there is a hypoplasia of the mandibular bone that is noted down in these individuals. So this would be the particular picture of a child who is suffering from mandibulofacial dysostosis. They have their own complication. They suffer from a low IQ, arched palates, telecanthus. All of these would be the features noted down in these individuals. When we weigh these features, we have the ocular features, and on the other hand, we have the systemic features in these children. They suffer from a coloboma of the lower eyelid and anti-mongoloid slant. So that is how you differentiate it from a child who's suffering from Down syndrome, who has those mongoloid features. An indistinct inferior orbital margin is noted down, a bird-like face that is slightly elongated or an ovoid face. In these individuals, external ear deformities are quite importantly noted because it's not an isolated condition. Obviously, if the facial features are going to be affected, it can be the ear, it can be the arch of the palate. All of these are affected. For example, they may be suffering from microstomia with a high arched palate. So eventually, even the dentition is going to be affected in these children. Then we have another syndrome, which is known as a median facial cleft syndrome. So there would be that cleft palate, a cleft lip. The child may be suffering from an isolated condition in which there is no cleft lip and it's just a cleft palate. And it can arise in a syndromic kind of a condition in which we have the cleft palate in the baby, the cleft lip is observed in the baby, and there would be the features that are also going to affect the orbital cavity in these features. Again, there would be the compression effects that are noted down in these babies. The features would be consisting the main ocular features. Obviously, mainly the baby would be having a cleft palate, but obviously the orbital cavity is also going to be affected due to that premature closure of the other sutures. So the baby may be suffering from hypertelorism as well as telecanthus. They may be suffering from a divergent squint that is noted down in these individuals. Then the main systemic features would be a cleft nose, lip, and palate. Obviously, it is going to be surgically treated, and a V-shaped frontal hairline. So these are the particular features when we look at the individual on a whole, and how are you going to observe the ocular features in these individuals as well. Another syndrome, which is commonly known as Apert's syndrome, Acrocephaly-Syndactyly, that is one of the features over here. We have an irregular dentition that is noted down in these individuals. Again, there would be hypoplasia of the maxillary, of the mandibular bone, specifically that these children are suffering from. So this would be the kind of condition that is noted down in this syndrome, which is known as Apert's syndrome. The systemic features would be a tower skull with a flat occiput. Then these children can suffer from mental retardation, and you can just obviously observe the milestones in these children, and that would reveal that these children are suffering from some sort of a mental retardation. VSDs, that is the ventricular septal defects, are quite common. Again, as I've already emphasized on the fact that it's mostly a syndromic condition and not an isolated condition that is observed in these children. High arched palate is one of the condition. Syndactyly of the fingers and the toes is also noted down. So usually these two words, that is the acrocephaly and syndactyly, these are given to the systemic features like this. The ocular features would consist of hypertelorism, congenital ptosis, bilateral proptosis due to shallow orbits, they are also noted down. Then we have the anti-mongoloid slant, that is again one of the features of the Apert syndrome over here, and a divergent squint. So you can just collectively just summarize the ocular features over here that are quite particular to the Apert syndrome. The other ocular features or the ocular associations would be a keratoconus that is observed. Then these children may be suffering from a congenital closed angle glaucoma, as well as ectopia lentis. Abnormal positioning of the lens is sometimes noted down in these individuals. So hypertelorism is again one of the conditions, and that is again arising due to the premature closure of the sutures in these individuals. There is an increased interpupillary distance, divergent squint, and telecanthus is usually observed in these children. Due to this divergent squint and due to this compression of the orbital cavity, you would observe that there is an optic atrophy that is noted down in these children. Hypertelorism is a symptom. It's just a sign that is usually observed in the different syndromic conditions. May it be the Crozen syndrome or may it be the other facial dystrophies that we observe. In some cases, by a narrow optic canal, the optic canal is narrowed down and it's compressing on the optic nerve, and that is the reason of the optic atrophy over here. Anti-mongoloid slant is noted down in these children. The orbital infections or the preseptal cellulitis is one of the orbital conditions. Having done with the congenital anomalies, now we know that there are multiple acquired conditions that can occur in the orbital cavity. That would basically encompass the infections of the orbital cavity. Again, we can further classify these infections to be of a bacterial origin, a viral origin, a fungal origin, or the autoimmune disorders can sometimes raise up an inflammatory reaction in these individuals. We usually come across this preseptal cellulitis. Now, the word preseptal is basically indicating that the infection is basically lying anterior to the orbital septum, and usually it's the structures that are the neighboring structures, the skin, the tissues are sometimes involved. It's not the pure infection of the orbital cavity. The etiology over here regarding the preseptal cellulitis, the organisms that are usually involved in this kind of a condition, the organisms are pertaining to the skin infections. As you all know, that is basically the Staph aureus, which is the nosocomial flora of the skin, and that can sometimes infect the individual if the individual has a lower immunity. So it can be the infections with the Staph aureus, it can be the infections of the Streptococcus pyogenes, and even the Haemophilus influenzae. These infections usually flare up and give up a picture of orbital preseptal cellulitis in patients of acquired immunodeficiency syndrome or other conditions in which you have malnutrition is one of the notorious conditions in which these organisms would flare up or would start up a preseptal cellulitis in the patients. The modes of infections are usually following a skin laceration, so any trauma to the skin, any open wound inside the skin, insect bites, surgical procedures can even flare up these infections that can ultimately result in the preseptal cellulitis. Then there can be the extensions from the local infections, that is the acute hordeolum or the acute dactylocystitis. So it can be the sinuses that are one of the neighboring structures lying over here. It can be the nasal cavity, it can be the brain infections. All of these can finally communicate and end up in a preseptal cellulitis kind of a condition in the individuals. The endogenous infections, meaning coming from within, would be the hematogenous spread from a remote ear infection. So obviously, The ear cavity is not in direct relation with the orbital cavity, but it would be a hematogenous spread through the lymphatics or through any hematogenous continuation that the spread would be made to the orbital cavity. The clinical features of the preseptal cellulitis would include a painful acute preorbital swelling. So that would be the main feature over here, and that would end up in erythema and hyperemia of the lids, as well as the proptosis is absent in these individuals. Usually it's quite normal, or ocular movements are quite in a normal phase in these patients. These children usually suffer from fever and leukocytosis, as well as there would be, when you would examine the visual acuity in these patients, you would observe that there is no difference in the visual acuity made after this infection. So it's not an infection that is involving the inner structures. It's just a localized infection to the skin and the tissues of the structures that are involved or that are lying anterior to the orbital septum. The treatment regarding the preseptal cellulitis would include the systemic antibiotics, first of all. The patient would need warm compresses along with that, systemic analgesics. This is all the supportive kind of treatment that you would be giving to the patient. Surgical exploration is done. So if the cyst is big enough, if the abscess is big enough, you can perform the I&D procedures, that is the incision and the drainage procedures if they are indicated. You can perform that, but that would be only coupled up with the topical antibiotics or the systemic antibiotics that are usually given to these patients. Then for mild to moderate cases, the oral coamoxiclav, 500 per 125 milligrams, that is 3 times daily. Flucocloxacin, 500 milligrams, QID for 10 days. And in severe cases, hospitalization for IV ceftriaxone is done. 1 to 2 grams per day in divided doses for 4 to 5 days. So this is the complete course of the antibiotics, the systemic antibiotics per orally. We can suggest or we can prescribe to such patients of preorbital cellulitis. The orbital cellulitis and the intraorbital abscesses are sometimes noted down. So sometimes it's an abscess which is quite deeply located, or infections that are located posterior to the orbital septum, that would be included in the orbital cellulitis or in the intraorbital abscesses. So these would be the terminologies. The picture again would be the swelling, the redness, the irritation would be noted down in these patients of orbital cellulitis. The modes of infections would be there can be an exogenous infection due to the retention of the foreign body or due to any trauma that has occurred to the orbit. Even after following the surgical procedures, you can observe this orbital cellulitis or these abscesses. The extension of the infections from the neighboring structures can be noted down. We can have the paranasal sinuses, and we can have the lids that are involved in these individuals. The intracranial cavity and the face is sometimes included. On the other hand, we have the endogenous infections that rarely develop as the metastatic infections from the brain abscesses. So sometimes the infections can travel quite remotely, and they can enter the orbital cavity and can finally result in an orbital abscess or an orbital cellulitis in these patients. The causative organisms over here would be the Streptococcus pneumoniae. We can have Staphylococcus aureus, the Streptococcus pyogenes, and then we can have Haemophilus influenzae. So these can be the causative organisms that can eventually end up or flare up the orbital cellulitis in the patients. The pathology would include an infection that establishes early due to the absence of the lymphatics in the orbit. So this is one of the points that the condition is usually quite an acute and a condition that arises or flares up quite acutely due to the absence of the lymphatics in the orbital cavity. The rapid spread with the extensive necrosis is noted down. The infection spreads as thrombophlebitis. The rapid change is produced in this orbital cavity, and that is usually associated with an increased intracranial pressure in these patients. The orbital cellulitis and intraorbital abscesses have their own symptomatologies. The swelling and the severe pain is noted down in these individuals. Along with that, obviously, it's going to be a systemic kind of a condition. So the patient may be suffering from fever, extreme nausea, as well as a vision loss or diplopia is also complained of in these individuals. The signs would be the swelling of the lids, and you'd perform the rapid reflexes, that is the pupillary reflexes, and the axial proptosis is noted down. The restriction of ocular movements is noted down, and there would be chemosis of conjunctiva, or either the patients would be suffering from papilledema when you'd perform the fundoscopy in these patients. The complications would include the exposure keratopathy due to the inability to close the lids. There can be the features of keratopathy. Either it can be the keratitis, or either it can be the ulcerations that occur at the corneal level. Optic neuritis may be noted down due to the effects of the compression, due to the cellular infiltrates that accumulate. There would be marked swelling of the structures of the orbital cavity. Subperiosteal and orbital abscesses would be seen. And obviously, if you just note down these abscesses or the collection of the pus, you can perform the incision and the drainage procedures in these patients as well. Then the patients might be suffering from intracranial complications as well if the infection spreads via the cavernous sinus or via the lymphatic drainage to the abscesses or to the cranial fossas, that is the interior or the middle or eventually the posterior cranial fossas. Then we can have the general septicemias, and there can be a widespread infection or a septicemic condition due to this orbital cellulitis if it is left untreated or if it is ignored. The investigations would be to perform the bacterial cultures on the pus that is accumulated. A complete hemogram, that is the complete blood counts, would be taken, the LFTs, RFTs, so the baselines would be performed in these individuals. X-rays and orbital ultrasonographies would just reveal the fact of the extent of the infections, if it has involved the neighboring cavities or if it has involved the neighboring structures or not. Finally, we'd perform the radiological imaging techniques. For example, the CT scans and the MRIs are also sometimes indicated for these individuals. The treatment would include the antibiotic therapy in these individuals. Then you can also perform, or you can also prescribe analgesics as a part of the supportive therapy that is given to these patients. You would be giving the NSAIDs just to lower down the inflammatory condition that has arisen. The topical eye ointments are given, nasal decongestants are given, and you would re-evaluate 2 to 3 times daily if there is any need of surgical intervention or not. And finally, you would revert to surgery if it is not responding to this antibiotic systemically and topically. You would finally, the final treatment guideline would be to perform the surgical procedures and perform the debridement procedures in these patients of orbital abscesses. The treatments over here would immediately canthotomy or cantholysis is done for these patients. You perform a free incision to the abscess under the skin. And finally, there would be a subperiosteal abscess. You would reach that area of the final cellular infiltration and you would perform the abscess drainage in this patient. On the other hand, once we have discussed the the bacterial origin of the infections in the orbital cavity, that is due to the Staph aureus, the Streptococcus pneumoniae, or the Haemophilus influenzae, we have another variant of the infections over here, that is the fungal infections that can occur in the orbital cavity. that would be regarded as mucormycosis. The primary organisms that are involved over here are the mucor, and then we have the rhizopus, that is the most notorious organisms for causing the fungal infections. The predisposing conditions would be diabetes, it can be the renal failure, either it can be the malignant tumors, the antimetabolite or steroidal therapy, or if the patient is in an immunocompromised state, otherwise it can be one of the states that arise in cases of malnutrition. The features over here would consist of pain. Then the patient would complain of proptosis. It would be a particular sign that is noted down by the clinician himself or herself. The necrotic areas with a black ascar would be a particular highlight of this fungal infection. This ascar is one of the predominant signs of the fungal infections of the orbital cavity. The complications can include the meningitis that can occur in these patients, as well as they can suffer from brain abscesses. So if the condition is left untreated, it can involve the neighboring structures, it can involve the nasal cavities as well as the sinuses as a complication. The final diagnosis is based upon the biopsy that is taken of the ascar. The finding non-septate broad branching hyphae is the major finding when you look at the biopsy features and you look for the histological features of the fungal infections. The treatment would consist of correcting the underlying disease in these individuals, the surgical excision of the involved tissue, the intravenous amphotericin B. So this would be the systemic treatment that is given to these patients, and the exenteration for the unresponsive cases, that is, you'd revert to the surgical intervention in patients who are not responding to the systemic therapy. Another condition which can arise is the cavernous sinus thrombosis. There are a lot of communications from the orbital cavity to the cavernous sinus. This diagram is explaining quite well the different communications over here. As you can observe, these are the different structures over here. You can just relate or appreciate over here that this is the cavernous sinus lying just over here and is quite significantly communicated with the orbital cavity through the ophthalmic veins. So these are the different communicating features that are draining the blood from the facial features, and it basically involves the frontal ophthalmic vein. We have the angular vein, the maxillary sinus, we have the deep facial vein, and all of these veins ultimately, the pterygoid plexus inferiorly, all of these ultimately drain into the cavernous sinus. So this is a very important communication. The infections can basically travel from the facial features towards the cavernous sinus, and they can cause the cavernous sinus thrombosis. These infections can then ultimately travel systemically due to the fact that we have a superior and inferior petrosal vein, and that ultimately drains into the lateral sinuses. So these are very important communications, anatomical features that you have to remember and apply it clinically. These are the different veins that are ultimately draining into the cavernous sinus. So these cavernous sinus communications, that is, there is an intercavernous sinus, then we have a superior ophthalmic vein, that is basically draining into the cavernous sinus, and this cavernous sinus is ultimately draining by the inferior and superior petrosal sinuses into the lateral sinuses. So these are the superior and the inferior petrosal sinuses draining into the jugular sinus, is also draining ultimately into the lateral sinuses, and these are the very important communications. These communications are basically a way of the infections to travel distally. The features of cavernous sinus thrombosis would relate of the severe pain in the eye and a swollen conjunctiva. Proptosis and ipsilateral ophthalmoplegia is noted down. High-grade fever with chills and rigors, and along with that we have ipsilateral ptosis and a dilated pupil. The features would include the edema in the mastoid region, corneal anesthesia, vomiting and headache, and fundus examination would reveal a normal study, but a little papilledema is noted down in these patients. The investigations that you would carry out in these patients would be a CT scan of the head is done. Then you would perform the MRIs for these patients, the angiographies are done, and finally you would perform the blood cultures. The CT scans or MRIs are basically done to know the extent of the infections, the spread of the infections, and the level of the damage that is done. And then you would basically start off with the treatment modalities that are available out there. If this condition is left untreated, these patients can complicate with hyperpyrexia, pulmonary infarction, and as well as there would be the signs of meningitis noted down. The features would consist of cornea, anterior chamber, and on the other hand, if we have a CST that basically clears in its early stage, it's basically a comparison, just to give you a comparison of the features over here. The laterality of the condition in the CST is initially unilateral, but soon it becomes bilateral, while in orbital cellulitis, it's mostly unilateral. Proptosis and edema in the mastoid region is noted down. It's of moderate degree in CSTs, and proptosis as well as we also note down the mastoid region edema in these patients. There's a marked degree of proptosis in orbital cellulitis as well as no mastoid region edema is noted down. General symptoms of fever, they are quite marked in CSTs, while in orbital cellulitis they are quite mild. So this is a comparison between the orbital cellulitis, or if this orbital cellulitis has involved the cavernous sinus and finally it is ending up in the cavernous sinus thrombosis. We can also relate to these conditions as CST to be one of the complications of orbital cellulitis. When we consider the vision and the ocular movements, the vision is not affected early. Either it is the complete limitation or the palsy. The vision is not affected early and there is a marked limitation noted down. Knowing the differential diagnosis of panophthalmitis, either it's unilateral, mild general symptoms or fever, moderate degree of proptosis, vision loss is starting from the beginning. The haziness due to the corneal edema, pus in the anterior chamber is noted down. There is painful and limited eye movements in panophthalmitis, and edema in the mastoid region is also absent in panophthalmitis. So we have to rule out panophthalmitis whenever we are considering or whenever we are having patients of CSTs. The treatment would be to start off with antibiotics, analgesics, anti-inflammatory drugs, and anticoagulants. So in this lecture, basically, we summarized the different congenital conditions, first of all, that can arise in the orbital cavity, as well as the miscellaneous infectious states that can also arise in the orbital cavity. Most importantly, we have the emergency conditions, for example, cavernous sinus thrombosis. How do we deal with these complications and how do we treat these conditions? That is the mainstay over here. So that is the end of this lecture. Thank you for watching sqadia.com.